1, 2,
And here. 70-year-old female.
Oh shit, I got some blood going. Oh, he's wearing it too.
You're in the bay. Once you get over to the bed, we'll give you the story. Everything's going to happen super fast. Welcome to the emergency room.
I lost the phone.
Let's start with
300 please.
I'll keep your number again.
Pulse check. No pulse.
no more pulse.
Yeah. Here, what are the echo people get? And her blood pressure is off the dropping.
45 minutes of CPR and no return of circulation. Okay.
Welcome to the deep dive. So if you are a nursing student prepping for your maternal newborn exams right now, you are probably staring down just a mountain of textbooks.
Oh, absolutely. It's overwhelming.
Right. Like a massive list of medications, complicated clinical pathways. It really feels like you have to memorize every single possible scenario that could ever happen to a pregnant person.
And honestly, it is incredibly overwhelming if you try to absorb it all equally. You know, treating every fact like it's equally important.
Which you just can't do. So our mission today is to step into the role of your clinical mentors and exam coaches.
Exactly. We are going to aggressively apply the Pareto principle to your study material on labor and birth management.
Yeah, the 80-20 rule.
Right. Sifting through the noise, and focusing strictly on the 20% of the concepts, patterns, and really high-yield facts will actually get you 80% of your exam points.
I love that. No fluff, no endless reading of lists. We are hunting for the exact NCLEX-style traps, the priority interventions, and the safety alerts that nursing instructors absolutely love to test.
They do love their traps. But to navigate those effectively, we need a lens to look through. What is the fundamental non-negotiable rule that a student needs to anchor their clinical judgment to?
Well, the ultimate clinical priority is dual safety. You are always, at every single second, managing two patients simultaneously.
Right, the mother and the baby.
Exactly. You're constantly balancing the maternal physical status with fetal oxygenation.
And if you anchor your critical thinking right there and ask yourself, how does this specific action affect the mother, and how does it affect the baby's oxygen supply? Well, the exam questions really start to answer themselves.
Okay, let's unpack this by walking through a sort of chronological timeline of a high-stakes clinical shift. Let's visualize our patient.
Sounds good.
Because before we can even think about, strapping on a fetal monitor, we have to properly assess the mother coming through the doors. Triage basically dictates everything that follows.
It does. And often, that very first triage assessment actually happens over the phone.
Oh, right.
Yeah, exam writers love to test your ability to differentiate between just expected, premonitory signs of labor and a situation where you need to tell the patient to get to the hospital immediately.
So on the phone, you're assessing things like their estimated date of birth, their gravida and parity history, the frequency of fetal movement.
And the characteristics of their contractions, exactly.
Yeah. You also ask about bloody show and whether their membranes have ruptured. But I really want to pause on that last one. Why is membrane rupture such an immediate red alert trigger?
That's a great question.
Is it just the practical issue of, not wanting the patient to deliver in their car on the highway?
Well, no, it's actually rooted in physiology and infection control. The amniotic sac is a completely sterile barrier. It totally protects the fetus from the outside world.
Okay.
So the second those membranes rupture, that barrier is just gone. Vaginal flora can now ascend directly into the uterus, which immediately starts a ticking clock for chorioamnionitis.
A severe infection.
Exactly. And there's also the immediate mechanical risk of a cord prolapse.
Oh, wow. Right.
Yeah, that the baby's head isn't fully engaged in the pelvis when all that fluid gushes out. The umbilical cord can literally wash out past the head.
Which means it gets compressed.
Right, compressing the baby's actual lifeline.
Okay, so a ruptured membrane means immediate evaluation. Now, let's say she arrives at the unit. We transition to the in-person admission assessment.
Right, getting the maternal health history, vital signs, checking fundal height.
And doing a vaginal exam to check cervical dilation, effacement, and fetal descent. But I always see this highlighted in the sources. The very first thing done upon entry into the labor and birth area is a 10 to 20-minute continuous fetal heart rate assessment.
Yes. That initial 20-minute continuous monitor is your absolute baseline.
Which makes sense.
You have to establish how the fetus is tolerating its current environment before the intense Prolonged stress of active labor really kicks into high gear.
I always think of that initial continuous monitor as being kind of like a mandatory credit check before a bank gives out a massive loan.
Oh, that's a brilliant way to put it.
You need to know exactly what the baby's oxygen reserves are before you put them under the massive physical stress of uterine contractions. I mean, you can't safely proceed without knowing their starting tolerance.
The credit check analogy works perfectly for visualizing the baseline. But remember, and this is key, the baseline alone doesn't give you a pass to just ignore the patient for the next hour.
Right, of course not.
It dictates the frequency of your ongoing monitoring. This is a major priority action and a huge exam trap. You absolutely cannot confuse the rules for intermittent versus continuous monitoring.
Oh, right. What are the strict rules there?
Well, if you have a low-risk patient in active labor, you use intermittent auscultation every 30 minutes. But if they are high risk in active labor, that interval drops to every 15 minutes.
Every 15 minutes. Got it. And obviously, if the mother or baby's status changes, we adapt.
Exactly.
But what happens if the external monitors just aren't giving us a clear picture? Say the maternal habitus makes it difficult to pick up the heartbeat, or the baby is just moving around erratically.
It happens all the time.
So if we need a closer look via continuous internal monitoring, can we just, switch to that?
You absolutely cannot just switch to it. This is highly testable. To place an internal fetal scalp electrode, you must meet a strict safety checklist.
Okay, what's on the checklist?
First, the membranes must be ruptured. Second, the cervix must be dilated at least 2 centimeters. Third, the presenting fetal part must be low enough to allow access.
And fourth?
And fourth, a skilled practitioner must be available.
I want to make sure I understand the mechanics of that restriction. Why this strict 2-centimeter dilation rule? Like, what's the reason?
It all comes down to physical access and maternal safety. I mean, an internal monitor is a small spiral electrode that is literally gently screwed into the superficial skin of the fetal scalp.
Oh, wow.
Yeah. So if the cervix is only 1 centimeter dilated, you physically cannot get the guide tube and the electrodes safely through that cervical opening without risking severe laceration to the maternal tissue.
That makes total sense.
So if a test question shows a patient with intact membranes or a closed cervix, internal monitoring is instantly the wrong answer.
Here's where it gets really interesting, though. Now that we have the monitors on, what are we actually looking at?
The tracings.
Right. Interpreting fetal heart rate tracings is kind of the holy grail of OB exams.
Yeah.
It's the one area where nursing students tend to panic the most because, honestly, it looks like a foreign language.
It definitely looks intimidating at first glance, but we can break it down into highly testable, manageable chunks.
Please do.
The single most important indicator of fetal well-being, write this down, is baseline variability.
Variability?
Yes. Variability represents the constant push and pull of the baby's sympathetic and parasympathetic nervous systems. The sympathetic nervous system increases the heart rate, while the parasympathetic slows it down.
Okay.
When both are healthy and well oxygenated, they constantly tug back and forth, creating tiny fluctuations in the baseline.
And the sources break this into 4 categories, right? Absent, which is a flat, totally undetectable line.
Right.
Minimal, which is less than 5 beats per minute of fluctuation. Moderate, which is 6 to 25 beats per minute. And marked, which is anything over 25 beats per minute.
Exactly. And the big flashing neon sign for students is that moderate variability. That 6 to 25 range is normal.
So moderate is what we want to see.
100%. When you see moderate variability on a tracing, you know the baby's nervous system is intact and they are well oxygenated. Now, let's filter the 3 overarching categories of fetal heart rate patterns. Category 1 is your normal happy baby.
The ideal scenario.
Right. The baseline rate is between 110 and 160. You have moderate variability, accelerations or early decelerations might be present, and that is perfectly fine.
And what's the absolute rule for category 1?
The absolute key rule is there are no late or variable decelerations. If you see this pattern, your clinical judgment is that it's predictive of normal fetal acid-base status. No intervention is required.
But then we have category 2. This feels like a huge exam trap because it is just so broad. It's literally labeled as the indeterminate group.
It's a very gray area.
Yeah, you might see tachycardia or bradycardia that still has variability. You might see minimal or marked variability, or even recurrent late or variable decelerations that are accompanied by moderate baseline variability.
Exactly.
Wait, if it's indeterminate, doesn't that just mean we don't know? Why even have a category that just says maybe on a medical exam?
Because that captures the clinical reality of watchful waiting in obstetrics. I mean, not everything is perfectly healthy or actively dying.
That's fair.
Category 2 means the pattern isn't definitively predictive of normal acid-base status, but it also isn't predicting severe hypoxia yet. It requires continued surveillance and reevaluation.
So how do you tell when it crosses the line?
The key differentiator, the thing that separates a concerning Category 2 from a terrifying Category 3, is almost always the variability.
Okay, so define that terrifying Category 3 for us.
Category 3 tracings are purely abnormal. They are predictive of abnormal fetal acid-base status, meaning the baby is actively hypoxic.
So priority action.
You must report it immediately.
Yeah.
Category 3 includes bradycardia, a baseline under 110 beats per minute, but specifically bradycardia combined with absent variability.
Absent variability being the key.
Exactly. It includes recurrent late or variable decelerations, again with absent variability.
Right.
Or it might be a sinusoidal pattern, which is this smooth, undulating wave that indicates severe fetal anemia.
Okay, so just to clarify, bradycardia with variability.
That is Category 2. Watch it closely.
Bradycardia with absent variability.
Category 3. Sound the alarm.
Wow, okay. And if we hit that Category 3, we aren't just calling the provider and waiting with our fingers crossed, right? We have to actually act.
Immediately.
The sources outline the priority interventions for Category 3 patterns. This is the Act Now sequence.
These are top-tier exam materials. First, notify the healthcare provider. Second, and this is a massive NCLEX, trap discontinue oxytocin or any other uterotonic agent immediately.
Stop the pitocin.
Never let pitocin continue to run if the baby is in distress.
Wait, let's look at why oxytocin specifically. I know it causes contractions, but why is that the absolute immediate enemy during fetal distress?
Because of how the placenta functions. During a strong uterine contraction, the blood vessels supplying the placenta are physically squeezed shut by the uterine muscle.
Oh, so it cuts off the supply.
Right. Blood flow, and therefore oxygen transfer to the baby, momentarily stops. A healthy baby has the reserves to handle those brief pauses.
Like holding their breath.
Exactly. But a hypoxic baby does not. If you leave the oxytocin running, you are forcing a suffocating baby to endure more contractions, completely cutting off what little oxygen they have left.
Stop the stress. That is step 1.
Next, turn the client. Move them to their left or right lateral, knee, chest, or hands and knees position.
Why do we move them?
Because this physically shifts the weight of the heavy uterus off the maternal inferior vena cava, which immediately relieves cord compression and increases placental perfusion.
Okay, that makes sense.
Then administer oxygen via a non-rebreather face mask to flood the maternal bloodstream with oxygen, which then crosses over to the fetus.
And then the IV fluids.
Right. After that, you increase the IV fluid rate to expand the maternal intravascular volume. That corrects any maternal hypotension that might be decreasing blood flow to the uterus.
I love finding patterns to help remember these sequences. If you get a Category 3 question, you should think, stop the stress, shift the weight, flood the engine.
Oh, that's really good.
Stop the stress by turning off the oxytocin to halt contractions. Shift the weight by repositioning her to relieve the cord and the vena cava. And flood the engine by pushing IV fluids and throwing on that non-rebreather oxygen mask to maximize perfusion.
Stop the stress, shift the weight, flood the engine. I mean, that is a phenomenal memory anchor. It captures the physiological mechanism behind every single priority nursing action.
That really simplifies it.
You also modify pushing efforts if she's in the second stage and prepare for an expeditious surgical birth if the pattern isn't corrected in 30 minutes.
Let's use causality to transition to our next major topic. We just spent all this time optimizing the baby's oxygen with fluids and repositioning, but what happens when the mother's intense pain kicks in?
That's a huge factor.
Doesn't her physical reaction to unmanaged pain negatively affect the baby?
It absolutely does. Severe, unmanaged pain causes maternal anxiety and hyperventilation. Hyperventilation blows off way too much carbon dioxide, which leads to maternal respiratory alkalosis.
And alkalosis is bad because...
Alkalosis causes the blood vessels to constrict, including the uterine blood vessels, which directly decreases oxygen transfer to the fetus.
Wow.
Yeah, pain management in labor isn't just a courtesy, it is heavily tied to fetal safety.
I'm looking at the non-pharmacological options listed in the sources. Continuous labor support, hydrotherapy, position changes, patterned paced breathing, and effleurage, which is that light stroking of the abdomen.
Right.
Do those actually work against the sheer force of labor, or are they just, distractions?
Oh, they definitely work. They work through the gate control theory of pain.
How does that work?
The idea is that pain signals travel up the spinal cord to the brain, but the gate can only process so much information at once. By applying a competing physical sensation like the warmth of hydrotherapy or the tactile friction of a fleurage, you essentially crowd out the pain signals.
You close the gate.
Exactly. Closing the gate to the perception of pain.
That makes total sense. Now, for the pharmacologic options, we're usually talking about systemic analgesia administered through an IV. The sources list a massive array of drugs.
They do.
Opioids like butorphanol, nalbuphine, meperidine, and fentanyl. They also mention atoractics like hydroxyzine and promethazine, as well as benzodiazepines. How is a student supposed to memorize all these?
It's a lot.
Is there a bigger physiological rule at play here? Like, why use an atoractic alongside an opioid?
Rather than memorizing the list, understand the mechanism. Opioids provide systemic pain relief, but a major adverse effect is severe nausea and vomiting.
Okay.
Atoractics, like promethazine, are primarily antiemetics. They control the nausea, but they also potentiate the effects of the opioid.
Potentiate meaning they make it stronger.
Exactly. This means we can administer a smaller overall dose of the narcotic to achieve the same level of pain relief.
Why is that so important?
Using less narcotic is crucial because opioids cross the placenta and can severely suppress the newborn's respiratory drive at birth.
Ah, okay. Now, the ultimate pain management tool seems to be the epidural block, but I notice instructors really love to test the timing of when it is administered.
Timing is everything with epidurals.
If the pain is incredibly severe early on, why not just give the epidural immediately?
Because an epidural is a regional neuraxial block that completely numbs the lower half of the body. If administered too early, typically before the cervix is dilated to at least 5 centimeters, it can drastically slow down or entirely stall the progression of labor.
Oh, I see.
The woman is an active participant in labor, and losing that sensation and muscle control too soon can impede the body's natural physiological progress.
What about general anesthesia? The sources note it involves an IV injection of thiopental to produce unconsciousness, then a muscle relaxant, intubation, and then nitrous oxide and oxygen.
Yes.
If it's the absolute fastest option available, why is it strictly reserved for extreme emergencies?
It comes back to the systemic effects again. General anesthesia crosses the placenta incredibly rapidly. When you push those IV medications to put the mother under general, you are also literally putting the newborn to sleep.
That sounds dangerous.
It is. This places the baby at a severe risk for respiratory depression, lethargy, and poor muscle tone upon delivery. We only accept the risk of general anesthesia when the mother or baby's life is in immediate danger, like a severe placental abruption. And we literally just do not have the 10 minutes required to safely place a regional spinal block.
So the epidural is working, the baby's tracing is category 1, and the mother hits 10 centimeters of dilation. We are in the second stage of labor. Time to push.
The second stage, right?
But I'm reading here that we shouldn't necessarily tell the patient to start bearing down immediately. Why? If they are fully dilated, shouldn't we just get the baby out?
It comes down to the mechanism of involuntary bearing down. Directed pushing before the fetus has descended deeply enough into the pelvis is just exhausting for the mother and highly ineffective. Worse, if she pushes prematurely against a cervix that isn't fully retracted, the friction causes the cervical tissue to swell and thicken, which physically blocks the baby's exit. You encourage the mother to wait until she feels a strong, involuntary urge to push.
Meaning the baby is ready.
Exactly, meaning the fetal head is naturally applying pressure to the pelvic floor.
So the pushing is successful and the baby is delivered. We pivot immediately to newborn care. We suction the airway and then dry them off.
Crucial steps.
Why is drying them off such a massive nursing priority? Is it just because they are, slippery?
No, it's about temperature regulation. Evaporation is the #1 cause of heat loss in a newborn. When they emerge covered in amniotic fluid, the surrounding room air rapidly cools their body temperature.
And a cold baby is a problem.
A huge problem. A cold baby uses up all their oxygen and glucose trying to stay warm, which leads directly to respiratory distress and hypoglycemia. Vigorous drying immediately removes that fluid, stops evaporative heat loss, and provides vital tactile stimulation to encourage crying and lung expansion.
Okay, now we enter stage 3, the delivery of the placenta. This feels like a massive exam trap area. What is the physiological mechanism we are watching for here?
You are primarily assessing for signs of placental separation. After the baby is born, the uterus drastically shrinks. The placenta, however, doesn't shrink.
Oh, interesting.
This size mismatch causes the placenta to basically buckle and shear off the uterine wall. You will see a sudden gush of dark blood, the umbilical cord will appear to lengthen out of the vagina, and the uterus changes from a discoid shape to a firm globular shape. When you see those signs, you instruct the mother to push to expel it.
And once it's out, we administer a bolus of oxytocin. We'll get back to the sheer irony of that in a minute. Let's move to stage 4. The first few hours postpartum. This is routinely taught as the danger zone.
It is the ultimate danger zone for postpartum hemorrhage. Your priority assessments in the 4th stage are taking frequent vital signs, checking the firmness of the fundus, assessing the perineal area, monitoring lochia, and this is a critical NCLEX favorite, assessing the mother's bladder status.
Why is the bladder such a massive priority when we're worried about uterine bleeding? I mean, they seem unrelated.
Visualize the pelvic anatomy. The uterus sits directly behind the bladder. After birth, the uterus needs to clamp down, to contract fiercely, to act like a living tourniquet.
To seal off the blood vessels.
Yes, sealing off the massive open blood vessels where the placenta was previously attached. If the bladder is full of urine, it acts like an inflated balloon.
Oh, wow.
It physically pushes the uterus up and deviates it to the right side of the abdomen. A displaced uterus cannot contract effectively. It becomes boggy and relaxed, which means those massive blood vessels stay wide open, leading directly to a life-threatening hemorrhage.
So assessing the bladder and encouraging voiding isn't just a comfort measure. It is a mechanical, life-saving hemorrhage prevention strategy. That visual makes total sense.
It really helps to see it mechanically, yeah.
All right, we have covered a massive amount of clinical ground today. If you are listening to this right before walking into your OB exam and you only have space in your brain to remember 5 things, here is your ultimate survival guide.
All right, number 1, always establish your baseline first. You cannot safely administer labor-inducing drugs without a 10 to 20-minute continuous fetal heart rate assessment on admission.
Number 2, variability is king. Remember the push and pull of the autonomic nervous system. Moderate variability, that's 6 to 25 beats per minute of fluctuation, means you have a happy, well-oxygenated baby.
Number 3, Category 3 means SOP and EVECX. If you see absent variability with bradycardia or recurrent late decelerations, use our anchor. Stop the stress, shift the weight, flood the engine.
Right. Discontinue oxytocin, reposition the mother, apply oxygen, and push IV fluids.
Number 4, epidural timing matters. To prevent stalling the natural progression of labor, they are usually started when the cervix is dilated greater than 5 centimeters.
And number 5, 4th stage safety is entirely about preventing hemorrhage. Always check the firmness of the fundus and constantly assess the bladder. A full bladder mechanically displaces the uterus, prevents it from clamping down, and causes massive bleeding.
If you master those 5 concepts and constantly apply the lens of dual safety, you are well on your way to thinking like a prioritizing safe OB nurse.
So what does this all mean? It means the overwhelming world of obstetrics isn't just a random list of facts to memorize. It is a highly interconnected web of physiological cause and effect. You now have the tools and the memory anchors to look past the distractors and find the safest path forward.
I want to leave you with one final clinical judgment puzzle to mull over on your own. We discussed at length how you absolutely must discontinue oxytocin during a Category 3 tracing.
Right.
You turn it off because the contractions are cutting off the baby's oxygen supply. But think about the 3rd stage of labor, literally minutes later, right after the baby and placenta are born. We suddenly administer a massive bolus of oxytocin. Why? The complete reversal. Consider how the nurse's goal for the uterine muscle completely flips the exact second the baby is safely breathing room air.
That is a brilliant mechanism to leave off on. We'll let you connect those final dots. Best of luck on your exams, trust your preparation, and we will catch you on the next deep dive.